Alright, this is going to be Chapter 15, History Taking. And after completion of this chapter, you'll be able to understand the need for an accurate medical history to provide competent patient care, using a comprehensive medical history to discover as much information about the patient's complaints, interpersonal relationships, and medical history as possible, using a focused health history to generate a historical findings necessary to manage an emergent medical condition, the benefits of asking open-ended questions so patients are allowed to answer in their own words and generate less biased history. So first of all, history taking, and it is the most important skill to master, defined as the medical questioning of a patient to determine the disorder, syndrome, or condition affecting the patient that resulted in the call for assistance. Physical exams and tests assist the paramedic in diagnosis. History must be consciously gathered on a patient-by-patient basis and a case-by-case basis. History and chief concerns must also be confirmed with the patient. The art and science of history taking. History taking. Science of asking the right questions, essentially, and the art in it is developing a relationship very quickly, too, that allows the paramedic to ask the right questions and also allow them to get the right answers from the patient. Best way of starting this off is open-ended questions. We should have some considerations for setting the stage. Whenever you look in the overall environment, and this comes with practice and interaction with the patients, any medical records that are available there, they should be looked at. Make the patient feel comfortable, be respectful of their personal space, watch for nonverbal clues. If you look neat and clean yourself, a professional appearance implies that the paramedic will be proficient medical provider. Essentially, if you look the part, then you'll be the part. Take shorthand notes. Gloves work great for that. Paramedics should formally introduce themselves and avoid demeaning terms like honey, baby, things like that. Start the interview. Whenever we start the interview, start it off with open-ended questions, and as you start getting information, you can kind of lead the questions to assist you through the interview. Techniques that might assist the paramedic include facilitation, reflection, clarification, interpretation, and direct questioning about feelings. Structure and content of the patient history. Several individual elements provide the structure. Comprehensive medical history, taken to discover as much information about the patient's concerns and interpersonal relationships and medical history as possible. We can receive medical history from all forms and fashion. What you're seeing here, this is figure 15.1 in your book, is the vial of life, and this can provide important information about the patient's past medical history as well as allergies and current medications that they're taking. Always be cautious when taking information from this. They might have, over the last couple of days, got new medications that they haven't updated their vial of life yet. Interviewing techniques. This is table 15.1. Facilitation. Actions that the paramedic nodding his head and acknowledging that the patient's there, saying things like go on, and acknowledging their actual interaction or what they're telling you. Reflection. Repeating the patient's words may encourage additional responses. So if they kind of stammer, stutter, or stop speaking to you, so to speak, repeat the last sentence to get them kind of started again. Clarification. Make sure to clarify statements when unclear or vague. Empathetic response. Try to show the patient's acceptance and understanding of how he or she feels. Confrontation. When there's inconsistencies in the story, don't be aggressively confronting them, but confront them about the facts that you perceived and to see if that's what they actually meant. Interpretation. A step beyond confrontation in which the paramedic, as the history taker, actually makes an interpretation of the patient's words or actions and presents it to the patient. If they can't quite formulate something, you may want to push them or help them in the right direction if you kind of have an idea of what they're speaking about. The focus history. Considerations in this are going to be the chief concern, and this would be our chief complaint. This is going to be the main reason for the medical care. best discovered through open-ended questions. If feasible, use the patient's own words to generate this. History of present illness, and there's a nice mnemonic for this. OPQRST, ASPN, and this is table 15.4, and we'll take a look at it here in just a few minutes. Can be used for the concerns of any pain. Avoid leading questions whenever you start interacting with them. Questions that may direct towards a given answer. So they're vague about the chest pain or something like that, but instead of taking their own words, you start applying words. An example of this: are you having any pain anywhere that I should be aware of today? Might be the open-ended question. And they say, well, yes, a little bit here in my chest. At that point, whenever you interact with them, asking them, well, does it feel like pressure? Yes, it feels like pressure. That's kind of a leading question. Try to get it in their words as much as possible. You might have to bump them in the right direction. An example of this was instead of asking them if it's chest pressure or dull or whatever descriptive term that you want to ask for that, instead of asking him that and kind of leading the question, can you describe that chest pain a little bit better for me? At that point, if it's obvious that they're having chest pain and they've told you they're having chest pain, but they're kind of vague on the description, isolate that down and get their reflection on it a little bit more. Past medical history and current health status. Focus on significant historical items of the patient. All patients must be questioned about chronic illnesses. Very simply, if it looks like a duck, walks like a duck, and talks like a duck, there's a good chance it's a duck. So if they've had asthma in the past and they're having shortness of breath today and you're hearing wheezing, there's a good chance that it's probably from the asthma. Allergies. Inquire about allergies and reactions. Medications. Ask the patient about any medications they use and inquire about prescription, over-the-counter, homeopathic. There are lots of all-natural vitamins out there that could give a patient that has cardiac symptoms, or give a patient that has any kind of cardiac history, cardiac symptoms. Tobacco, alcohol, and drug use, any kind of significant risk factors in that. And this is sampled. This is a nice acronym to remember. Table 15.3. Signs and symptoms, allergies, medication, past medical history. Lists whatever is important based on chief concern, meal, doctor's visit, menses, and so on. Events leading to the chief concern, and then does the patient have any advance directives? Healthcare proxy or anything like that. This is OPQRST ASPN, which is onset provokes quality region. This is for pain. Where does it hurt? What time did the pain start? Anything make it better or worse? What's the quality? Is it dull, sharp? Give them some options if they need to be pointed in the right direction, but don't specifically tell them or lead the question. Radiation, does it go anywhere? Is there any relief? When does it reoccur? Severity on a scale of 1 to 10, 10 being the worst pain you ever felt in your life. What do you think this is? Timing, when did it actually start? And that's also the onset. Does it come and go? Associated symptoms, any other symptoms? Does the patient have any long symptoms along with the chief concern? And pertinent negatives. A pertinent negative is like whenever they're short of breath and you're listening to the back of their chest and you don't hear any wheezing. They're moving air well. So the shortness of breath, you just had a pertinent negative for a bronchospasm. But then again, you need to find out why they're short of breath. This is a universal pain assessment tool, figure 15.2, and on a scale of 1 to 10, 10 being the worst pain you've ever felt in your entire life, where does the patient rate? We do this quite often, but if we don't have cooperation from the patient, we can kind of assess where they're at in this by just looking at their facial expressions. Other useful mnemonics, any concern of pain, OPQRST, ASPN, altered mental status. Whenever we get to neurology, we'll talk about this. AEIOU tips, shortness of breath, happy socks, all kinds of mnemonics out there to help us remember. Psychiatric depression and sad cages is a good thing to remember. So take a look at these. This is table 15.5 in your book. And table 15.6, past medical conditions related to specific body systems. Very simply, I'm going to cover a couple of these here. So, example, if they're having neurological symptoms today, a good past medical history that would have them having a stroke, seizure, or head injury would kind of be important. Same way with cardiovascular. Have they had an MI? They have any chest pain? Have they had a CABG or coronary artery bypass graft or any kind of angioplasty or stents put in? Respiratory, same way. Did they have a history of asthma, emphysema, smoking, hospitalization, or have they ever been intubated for an exacerbation of asthma or emphysema? Clinical reasoning, and this is based on the chief concern, history of present illness, and answers to direct questioning. The paramedic can develop a general sense of body systems that might be involved. Special challenges, sensitive topics. Sensitive topics are things might include such as drug or alcohol use, physical abuse, silence, many meanings. They could be collecting their thoughts or a result of insensitivity. Observe nonverbal clues. So if they're making their closed, an example of this, they'd have their arms crossed, they look aggressive. Watch for nonverbal clues or body language. Techniques that might be helpful on this. Overly talkative patients would be our next one. Are accepting a less comprehensive history, allowing a few minutes of free reign for the patient, allow them to just kind of go on and do their talking. Interrupt them very gently. Don't be abrupt on that. You don't want to shut them down, but you want to kind of peel them back a little bit or give them a little bit of rein, if you will. Reinforce or refocus the patient. An example of this would be like, so you said you had chest pain, or so you say you're short of breath. Patients with multiple symptoms, confounding factors are likely. Refocus on the most important concerns. Isolate on just if they're jumping everywhere. If they're jumping from, well, my head hurts and my toe hurts and my back hurts as well. Try to get a complete history best you can, but for the most part, isolate on the big ones. Anxious patient. Be conscious of nonverbal clues to the patient's anxiety. When he senses anxiety, encourage them to talk about their feelings if they have any. Could be related to a significant other. It may be related to money, responsibilities, all kinds of things. Reassurance can be beneficial or harmful. Reassurance that the patient is in good hands can always be helpful. Positive reassurance without creating a false expectation. So we don't want to give them false expectations. Whenever we reassure them, just say, hey, we're here to help. Let's go get you checked out, and let's all sleep better tonight. Let's see what's going on. Anger and hostility. Do not take it personally. Diffuse by identifying that you are there to help, and remember your safety. If you feel like that you're out of control, you probably are. Special challenges to history taking continued here. The intoxicated patient, calm direct voice, avoid confined areas, have an escape route. Crying, clue to emotions, be supportive, and wait for their recovery. Depression, this can have multiple manifestations. Maintain suspicion that those complaining of multiple vague symptoms. Any patient with the potential of self-harm must be transported to an emergency department for further evaluation. Seductive patients, prevent feelings from affecting professional interactions. Make the professional relationship clear. Confusing behaviors or history. Avoid dismissing patient concerns. Attempt to focus on a single chief complaint. Limited intelligence. Most can give adequate histories. If not, it is derived from other sources. An example of this would be caregiver, family, friends, medical charts. Use simple language. Listen closely. Don't make any assumptions. This kind of continued. Language barriers are difficult. The best translator is kind of neutral. If you need a translator, get one out there so that you can get better interaction and better history from your patient. Hearing impaired, look at the patient directly, speak slowly, avoid shouting. Written notes may be the only solution in this. Visually impaired, paramedics should make sure to identify herself, alert the patient to her location, and explain what's being done. Respond vocally, avoid shouting. May need to explain in more detail. Paramedic should grasp. The patient should grasp the paramedic's arm when walking. Avoid any kind of sudden movements. Families and friends, get the patient's permission to discuss the condition with others. If the paramedic cannot get permission, remember all medical information must be held confidential. In conclusion, the novice paramedic must master the skill of history taking. To be effective at providing care to the vast array of patients encountered, with practice and by observing other healthcare providers obtain a history, the novice paramedic will soon develop and refine her skill, or their skills. References for this are taken from Richard Beebe, Professional Paramedic, Volume 1, Foundations of Paramedic Care, First Edition, pages 242 to 255 of Delmar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@imsa.net, or 405-219-7613. Thank you.